Okay, just a quick background here in terms of low back pain internationally. As we look at 619 million people globally affected, and it's expected to increase to about 843 million by 2050. Unbelievable numbers of individuals around the world. Single leading cause of disability worldwide, experienced at any age, and most people experience low back pain at least once in their lifetime. And the prevalence obviously increases as we get to 80 years of age, and as you know, our populations are living longer and longer, so low back pain is going to be prevalent among so many of our individuals. More prevalent in women, as you can imagine, probably due to pregnancies and lack of muscle tone and all sorts of other reasons, but certainly more prevalent in women. Work productivity, we know around the world, is lost because of low back pain. It affects our quality of life, our mental image. There are so many factors involved. And when it's categorized, it's often categorized as being acute, and this is the definition that we tend to use now. 6 weeks or less is acute. Anything beyond that is now classified as chronic. And when I get to the guidelines, you'll see this again reiterated. It can be specific or it can be non-specific. We all know that for sure. And most cases of acute low back pain, the symptoms will probably go away if they don't do anything about it, and I hate to say that. However, I can tell you that the first incidence of low back pain that I see in many of my patients who are now in their 60s and 70s and 80s occurred when they were 30 or 40 or 50, and because they didn't take care of things early on, it becomes, again, repetitive as the age increases. This is just a very, very quick overview of a 2020 study that was done looking at the high-quality musculoskeletal pain clinical practice guidelines, and you will see this coming around again and again and again. Evidence is out there very, very strongly for it must be patient-centered. You've got to screen for those red flags. You've got to assess the psychological factors, which other speakers will talk about. Imaging should be used very selectively. I see high-powered MRIs being ordered all the time, and I can probably tell you, as many physios can tell you, what the etiology is of many of the underlying causes without that expensive MRI. Certainly the physical exam has to be taken. You've got to monitor progress. Evidence is there that you must provide education. So you'll see this again in all of the guidelines. And obviously incorporating physical exercise and physical activity is essential for these patients and clients. The guidelines also show that manual therapy should only be used as an adjunct and should not be used as a treatment in and of itself. Again, other high-quality indications that non-surgical care has got to be the indication prior to any considerations for surgery. In another review of high-quality clinical practice guidelines, the recommendations were very, very similar in terms of those I just talked about, and this has stressed the importance of the non-pharmacological treatment. And I think over and over again, I mean, I don't know how the opioid crisis here, but in the United States, we've had a huge opioid crisis. And it's, again, it's the easy fix, give them the pain meds and they'll get better and feel better, and that's the end of it. And unfortunately, we wind up with multiple problems. And obviously, there are differences in our health systems, which will make, again, interventions different from country to country. I was going to take some time to go into this in detail, but I'm just going to sort of breeze through this. But the key factors is, this is the low back pain decision tree. So when one is making a decision about low back pain, the following things should be indicated. First is assessing for pain-related psychological stress. And I'm not going to take any more because I know Jonathan is going to be talking about this later on. But the Start Back screenings tool is certainly one of those screening tools that should be considered very, very early on. I'm happy to share these slides with you if you want them, so I won't go through each of the entities and all of these specific tests. Again, the Start Back. The other is the ARBRO, which is the Musculoskeletal Pain Questionnaire, 25 questions altogether, also assessing for pain, particularly as it's related to psychological stress. And you can see, again, the entire pain questionnaire here and the scoring system. The OSPRO is another of those scoring. This is the yellow flag tool that I hope many of you are familiar with, because this again gives you a very, very good indication of what is going on with that individual, particularly as it relates to psychological stress. Just as an interesting aside, OSPRO means optimal screening for prediction of referral and outcome, so that's how the name of the terminology came forth. I've had many of my friends in psychology who have, again, been using this test very frequently early on, and I think it has a lot to say for itself in many aspects of our practice. Okay, then the next aspect of the entire decision tree is collecting baseline outcome data. And this will vary, again, from profession to profession, but certainly I'm going to be talking from a physio perspective. So the Oswestry, we all know in terms of the disability index, it's been out there for a long time, and certainly will give us very good baseline outcome information data. And again, let me just back up here a minute if I can. It does have 10 sections, and there are 6 items in each of the 10 sections, as you will see as I go. So pain intensity, personal care, lifting, walking, sitting, standing, sleeping, and sex life are all included, again, in the Oswestry. We also look at social life and traveling, again, as that last component of the Oswestry. Scoring is there, and this just gives you the determination of whether there's minimal or moderate or severe disability, or whether they're really crippled by the outcomes of the Oswestry. The other of the baseline outcome information systems that are used is the Roland Morris. I don't know how many are familiar with this, but this is also a nice questionnaire to use. It is 24 questions, so it takes a relatively longer period of time, but the patient will tell you exactly when their back hurts when all of these activities are gone through using the Roland Morris. And now we get to, again, collecting baseline outcome data, and we look at patient-specific functional scales, and that, again, now begins to give us much more indication of how they're actually functioning in the community and their daily life. Again, nice, easy questionnaire to be filled out, and again, good data. And then the classification, when we look at all of these things, of classifying this patient as whether they're acute, whether they're chronic, or whether they need medical or surgical interventions. Okay, so what are the next steps? We got to collect and interpret our physical examination data, and as you know, each of our professions will do things slightly differently in terms of data collection, but that's got to be done. And obviously, the constant thing that you will be hearing probably from all of us is that considering the patient perspective, that we just can't look at what we think is appropriate, but it's got to be really part of the patient incorporating into the entire process. Their beliefs, their motivations, their expected outcomes, all are, again, factors to consider, as are the barriers and facilitators for goal attainment. The next step in the implementation is the physical therapist collaborating to determine the treatment plan, and I use the word treatment, although I really have gotten away from the use of the word treatment. I use interventions all the time because I think treatment implies taking care of, and my responsibility is not to take care of. My responsibility is to facilitate my patient to make themselves better. And if I don't do that, I probably am not doing the best for them in the long run. So again, all of these things are going to be important, and the clinical practice guidelines are really going to be key in terms of what we're looking at, reassessing and then collecting, interpreting the data, and again, looking at whether surgical or other interventions are necessary. Now, when we look at the CPGs, we're looking at, again, obviously that data all of us are familiar with, again, the levels of evidence that are important out there. We obviously all want to see the highest level of evidence, and an awful lot of the studies don't reach that level, as we all know. And then we want to look at when that evidence is there, what are the grades of the recommendations? You know, is there strong evidence that the physio or the doctor or whoever should do this? Or again, they may do this, or they can do this, or they should not do this, is the result of when we look at these data. We have updated our guidelines in the States 2 years ago. The original 2012 guidelines did not differentiate the way our 2020 guidelines do, but the ones we use now are, again, the patient subgroups according to acute or chronic, and low back pain with leg pain, and also low back pain in older adults. So we now use these classifications rather than the ones we used in 2012. And then we have the post-operative low back pain as certainly our last classification system. Okay, I'm going to talk now about the exercise recommendations, since that's really the thrust of where I am today. We categorize, again, our exercise recommendations in terms of the definitions. Obviously, these are pretty straightforward. Trunk muscle strengthening and endurance exercises are pretty easy. That's that whole arena of core strengthening. Again, particularly improving strength and endurance and the power of those trunk muscles. And then there are the specific trunk muscle activation exercises, and those are the ones that probably came out of a lot of the Pilates work, getting that deep abdominal muscles, the transversus abdominis particularly, and getting that co-contraction to occur in order to stabilize the spine. Then we have what's called movement control exercise, and these are the ones, the functional movements, again, with feedback given during the movement patterns. Then we have general exercises, which are those, again, just used to restore the upper extremity, lower extremity, and trunk, again, strength and endurance. We have trunk mobility exercises, which we might look at as flexibility exercises, aerobic, obviously, to increase the aerobic conditioning. And I think with any patient with low back pain, I'm always interested in not only the strength and the flexibility of the trunk and the spine, but I am also looking at, again, their aerobic conditioning. So I always want to think about throwing some aerobic activity in as well. And then we have the multimodal exercise, which combines two or more of any of the others. Now, these were the 2012 recommendations, and I'm not going to spend time on these, but the grade A exercise for progressive exercise was there in the very beginning. There was grade A evidence for trunk coordination and strengthening. And in those days, there was grade A exercise for centralization. We've gotten away from that whole aspect of centralization, not entirely, but those who still adhere to Total McKenzie will still talk about centralization, but we didn't include it in the 2020 guidelines. Grade C studies, again, way back in 2012 for flexion exercises, and here we get to the 2021 recommendations. And here's what's really key for us now. The recommendation for exercise for acute low back pain, interestingly enough, is not should, but can. And that's a lot of the lesser standardization in terms of the physio should are based on the fact that there are just not enough adequate studies that have been reaching the level of evidence that we want them to reach. So it's not necessarily that it's bad or should not be done, but it's certainly, again, we've got to either get more data or we've got to go with the data that are available now. So the recommendation right now is that PTs can use exercise interventions. Grade B exercise for those with acute low back pain with leg pain that the physio may use, so it's slightly upgraded at that level in terms of the CPGs. For those with chronic pain, here the recommendations for exercise are really very strong. So I think that is the physio should be using exercise for those with chronic low back pain. They can provide movement control exercises and trunk mobility for those with low back pain, and they may use exercise training for specific muscles, again, for those with low back pain. When we look at those with chronic low back pain with, again, movement control impairment, again, the evidence is right up there at grade A that they should be using trunk activation and movement control exercise. Again, when we get to older adults, again, the data are very strong in terms of the clinical practice guidelines that exercise should be included for those individuals who, again, are in the aged category with low back pain. For those, again, who are post-operative, the level of evidence right now is relatively low, so that recommendation is that for those with post-operative low back pain, exercise certainly can be utilized. There's no negative information that says it should not be utilized. Again, here I think the lack of studies is probably one of the main reasons that it doesn't reach a higher level. Key points now for exercise interventions, as you can see, for acute low back pain, certainly we want to look at exercise interventions at multiple ends. For those with chronic low back pain, obviously exercise is recommended with no clear superiority to one type of exercise versus another. So I don't adhere to anything. I do a little mishmash of everything, as you'll see in a few moments. I do a little Pilates. I do a lot of yoga. I do, plain old exercise. So it doesn't really matter. We just know that you have to get people moving. For older adults, obviously, you've got to use the exercise, and for those who are post-operative, it may be recommended to reduce pain and disability. The surgeries in the literature search included lumbar discectomy, spine fusion, and decompressive surgery. The others were, again, indicated there. So those were the only surgical interventions that basically have been looked at in terms of data as it relates to exercise post-op. Okay, now the next area is the whole arena of manual and other directed therapies. And again, I don't need to go through the definitions here, but we have thrust or non-thrust mobilization, we have soft tissue mobilization, we have neural tissue mobilization, we've got massage, we've got dry needling, and we've got traction. So again, some of these areas will be covered again in later presentations. Again, they did not separate out in 2012, again, as I indicated, for acute and chronic low back pain. And in 2012, it was grade A for manual therapy and grade C for nerve mobilization and grade D for traction. And this hasn't really changed too very much, as you'll see with the 2021 recommendations. So here again, grade A recommendations for a should use thrust or other non-thrust mobilization to reduce pain in those with acute low back pain. Grade B, they can use massage and soft tissue mobilization, again, for those with acute low back pain. Again, for the 2021 recommendations, they should use thrust or non-thrust for chronic, may use it again for chronic with leg pain, and again, may use soft tissue mobilization and massage. So these, again, still have followed through pretty much from the original recommendations to 2021. As we get to the other directed therapies, they can consider dry needling, and I know we're going to be talking about dry needling. They may use neuromobilization, and they should not be using mechanical traction, which is really interesting. I mean, I think traditionally we've always thought of traction as one of those inherent aspects of PT practice, and again, the data are really relatively strong now not to use traction for the most part. Although I know in the States we have a whole series of private enterprises that are opening up that are basically doing just traction for patients with low back pain. So I think, you know, we've got to look that there are things out there, but again, the evidence doesn't support it. Again, for acute low back pain, again, the thrust and joint mobilization, massage, and soft tissue are included. For those with chronic, again, it's pretty much the same without traction. The whole series of classification systems is something people have gotten into over time. I don't generally jump on a bandwagon of any one classification system. I think it depends on if your clinic has an approach, it can be fine, but there's the mechanical diagnosis and therapy, and then there's a treatment-based classification. There's that whole movement system classification that we got on in the US for a long time and are now backing off a little bit. And then there's the cognitive functional therapy as well. There's the prognostic risk stratification and the pathoanatomic classification. So if you can figure out what to do with all those classifications, you're far better than I am, because I just have given up. I didn't know where to put my patients if I had to do this, so I just don't bother with classification systems at all. I mean, I read about them, I know about them, I know the colleagues of mine who embrace them. I just am using a much more probably holistic approach. Again, the guidelines out there is may and can for all of these in terms of acute and chronic low back pain. And again, this is just a quick summary of those key points in classification systems. Yeah, this is really key for all of us, and I think you have heard this partly this morning, and you're going to hear it again. Education is essential for these patients. And again, in the early days, in the 2012, they, again, should not use patient education and counseling strategies, but didn't say that they shouldn't. It was those that directly or indirectly increased the perceived threat or fear of the associated low back pain. So they were not saying don't use it as education. It was just don't educate your patient about all the negatives of what might happen with their low back pain. So I think that was really what happened in the 2012. And again, they did emphasize that we should promote an understanding of the anatomy and favorable prognosis and all of those things that we tend to do in management of our patients and clients. So our 2021 recommendation is that PTs may use active education strategies and may incorporate counseling on favorable natural history of low back pain. I do a lot of education with my patients. I just find that the more aware they are of what's going on, both in terms of what's going on with their body, but also in terms of what's going on with whatever interventions I might put, the more important it is for my patients and clients. And they should deliver pain neuroscience education for our patients and clients. Again, the other thing is the recommendation in 2021, when you compare it with other active treatments, that PTs should use active treatments. And again, I'm a big proponent of parts of yoga and parts of Pilates and obviously strength and aerobic training as well. For patients with postoperative low back pain, the recommendations are obviously that they may use education. Again, nothing negative that they should not. And the key points there are education should never be used as a standalone. I mean, obviously, it's going to be incorporated with many other different types of interventions. And then we have, again, for our patients, the conclusions for the postoperative patients, that education, again, has been studied post-op discectomies primarily. And this just gives you a summary of all of the things that I just talked about in terms of where the evidence is. And as I said, I'm happy to share these slides with you if you want. And here is the evidence for, again, chronic low back pain in terms of the decision tree. And again, the follow-up in terms of chronic low back pain. I just put up workers' comp guidelines. I don't know if you have a workers' comp system here in Poland or not, but we know there's a huge problem with injured workers. What we also know is that if we don't get them up and moving quickly, once they get into that syndrome, getting them back to work becomes extraordinarily difficult. So I just have shared these guidelines with you, again, that we look at the return to work is therapeutic, assuming work is not likely to aggravate. If it will aggravate, they should be given modified work. They should not be sent home to, again, wallow in their house if you can possibly avoid it. Active interventions, obviously including patient responsibility for workers, is particularly important. Exercise programs should include all of the things we've just talked about. And again, you want to constantly stress the functional gains. We know that if we can keep workers in the workplace and not have them go home over that 6-week, 8-week, 2-month, 3-month period of time, we have a very good chance of keeping them in the workforce as opposed to them becoming chronic, again, workers' comp victims. So reevaluating them very carefully, surgically, only when it's, again, totally indicated. And I think the key thing is that the prognosis drops precipitously for returning to work once they have been disabled for more than 6 months. If they've been out 6 months, the chance of them going back to work is extremely remote. And now I'm going to get into what I really love to do with my life. And if I can get somebody to drag my table to the middle for me, I'm going to try and go through a series of exercises. Normally, if I were teaching this really, you would all be in exercise clothes and you'd be getting down on the floor now. But since I can't do that here, I have my, thank goodness, volunteer. And what I've tried to do in this series of pictures, just lie on your back, is go through a whole series of different kind of exercises. I'll try to point out certain things as I go along. One of the key things that I always look at, and is I never adopt a hyperextension, philosophy. Everything's hyperextension, the old McKenzie stuff. I always, again, look at where that patient or client is. And just a couple of key factors. If I have my 70, 80-year-old woman who walks in with her forward neck and her kyphotic spine, am I going to have her do flexion exercises? Probably not. Do I need to strengthen the abdominal muscles? Absolutely. So I have to find alternate ways to do that so I'm not doing it in the same way. In the same way, if I have a patient with spinal stenosis and I have a patient with a spondylo, am I doing extension exercises? Probably not, because I've seen too many patients who come from other physios where they have been doing, again, press-ups and press-ups with, again, spinal stenosis, and they're not getting better, they're getting worse. Why would you do that? My attitude is, if those exercises are producing increased pain or not reducing the pain, why am I doing it anymore? So I'm going to find alternate ways. Not that I don't want to strengthen the abdominal muscles and the extensor muscles, because I do. I want that good core strengthening, but I'm never going to push my patient into pain. Some of the stretching I do, for example, I'm going to show a quick combination of straight leg raising. If my patient has acute radicular pain, am I going to push straight leg raising? Of course not. Am I eventually going to make sure that those hamstrings are elongated and I can get them again to be able to do the things I want to? Absolutely. But I'm going to be doing this again carefully and easily without producing pain. Again, my mantra has always been, no pain, no gain is not my philosophy. If there's pain other than the burn from good muscle contraction, I'm doing something that probably is aggravating that patient's problems and not leading to, again, beneficial effects. So I'm going to start with a nice, easy, probably just gentle pelvic tilt. And I'm very fussy about pelvic tilts. I want them to tighten the stomach muscles gently, very gentle pinch of the buttocks. I don't want them to push up on their heels. And I want her to tuck her chin down and in. So I'm getting that nice elongation of her spine. This is something I'll do very early. Remember, some of these things I'm going to try and show you progressions. I'm going to start out gently. If there's pain produced, then I'm going to think about doing something else. I can do some very gentle stretching, bringing one knee up to the chest and wrapping the hands around it, always making sure the abdominal muscles are tightened and the chin is in, so I'm constantly stressing that elongation, and obviously would do it on the other side as well. And then if I want to make sure their hip flexors are long enough, and as, again, if those of you who've treated enough patients with low back pain, you'll know those hip flexors are often tight. I certainly don't hang them over the table to begin with because that's going to arch their back. So what I'll do is have her wrap her hands around here if she can, stomach and chin in, and then slide this leg down gently and push the knee down to the table. So there I'm getting some nice hip flexor stretch. Again, as things go on and I can stretch it more, I'll probably do it in the on the kneeling position rather than doing it here. But this is a nice, easy way to start. And then obviously on the other side as well, and pushing that knee down. And again, I would progress it. I'm not just, okay, come back to the starting position. I'm not going to progress, but if you can just go down, that's the progression of if I want to increase, again, the a degree of hip flexor elongation, my next progression would eventually get to there. But this is how I'll start it because I know my patient is stable. Now, for those patients that I want to begin to strengthen the abdominal muscles, where I don't want to round the spine, what do? Okay, bring this knee to your tabletop, please. Oh, that's okay. Tabletop? Perfect. Good. Okay, take this hand, put it on your thigh. Press your hand to your thigh to your hand as hard as you possibly can. Okay, now I want everybody to sit up straight. In the chair, up straight, everybody. No, sit, stay seated, stay seated. I want you to put your right hand on your right thigh. And now I want you to bring that knee to your chest, but push it down with your hand as hard as you can. And what do you feel contracting? Your abs, okay? So this is a great way to start abdominal strengthening where I don't want to, again, flex the spine. And they'll get very nice. And what I'll do is I start this with a gentle hold of maybe up to 10 seconds and build it to 30. And then obviously the other side to make sure I'm getting right and left. And then what I'll do is right leg, left hand. So now I'm getting, as I crisscross over, I'm getting more of the oblique muscles coming in. And then again on the other side as well. So great way. And again, they can carry this out sitting at their chair during the day. As you saw, your abdominal muscles have to contract when you do that activity. If your patient is young and they can do flexion exercises, you can do flexion exercises with all sorts of hands behind your head. Okay, nice easy curl up, chin to your chest. And I never have them looking up to the ceiling because I don't want them to arch that neck. I want nice, again, if I'm looking at, again, major flexion and I feel okay with flexion, it's a nice way to do it. My progression is head and shoulders up, leg out in the air at the level of the opposite knee. Okay. And then bend it down, and then the opposite leg. Well, head and shoulders up first, and bend down. And then a progression of this is head and shoulders up, and both legs out at a 45-degree angle. And she's nice and strong. I don't know how many I could put up on the table here that'd be able to do this. And bend your knees first, and lower your head and shoulders. And then we get to some stretching of the hams, and I was hoping I'd have a band, but I don't. So we'll just show you one way to do this. Normally, I will work with a stretch strap to do this. So I have them straighten out the leg at the level of the knee or slightly even lower. Dorsiflex, and again, I'm having a band. So she's going to pretend she's got a band. As you notice, I have the elbows bent, shoulders are relaxed, chin is in, and then she'll raise up as high as she possibly can. And again, I always hold my stretches of at least 30 seconds, because if I don't, they're not going to get much elongation. And the progression of this would be to switch the band into, again, one hand, just pretend it's one hand, drop this knee to the side. Nope, no, to me, just there we go. And now that leg goes out, so we're now getting the inner hamstrings, obviously the adductor muscles as well. She's pretty tight there. Yeah, and then bring both legs back. Slide this heel down just a little bit, perfect. And with the band, she's going to bring the leg across, so we now get, again, the stretch of the IT band. So try some of these when you get home. You'll try, it's really fun. You'll be able to see how you all are. Okay, then I've just showed you that. Again, if I allow flexion, I also will do head and shoulders up, hands behind your head. Okay, and then legs to tabletop. Okay, and then bicycle. So elbow to shoulder as this goes out slowly, 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 slowly. Again, I never want this fast. I want those muscles contracting carefully. And this is, again, assuming that I can have my patient do flexion and assuming that I'm okay with rotation. Perfect. Okay, bridging is another nice component. Before you bridge, I start my patients just initially with a really early movement. Again, stomach and chin in, so they stabilize the spine, and all they're going to do is press the elbows into the table, but don't lift up. So just isometric contraction of my back extensor muscles. So this is a nice, easy way to get those back extensor muscles going. Obviously, the progression of this is then bridging up, so her butt comes up. And again, she's getting really good contraction of her glutes and her hamstrings and also her low back muscles, but she's also getting some stabilization of her abdominals at the same time. You okay? Progression of that is to straightening one leg out at the time. Good. And then holding it for prolonged periods of time and bend it down in the other leg. And then the progression of this is bend this down, rise up on your toes, and then straighten one leg out. And if you think this is easy, she's making it look really easy, just go home and try this. This is really hard. But great contraction and lower down and relax. Okay, great. All right, then let's get over and do some all fours. And again, onto your hands and knees. And we'll do just, you can again use the cat and cow that everybody does, again with yoga, just cat and cow. And then arch, but easy. And again, if I don't want my patient to hyperextend, I just have them come to neutral. So that's where my decision making goes. Okay, my progression then is I want you to just lift your knees lift your knees 3 inches up off the mat. Curl your toes under, curl your toes under. This way, good, okay? And then just lift your knees 3 inches. Good, and hold it. So this is a nice way to begin to get into a plank. And if you don't think this is hard again, if you've not been doing it, and lower down, good. And then I will, again, progress to plank. If they, again, want to do it on all fours, and let's just get into a plank on your, before we go down on, yeah. And I keep the butt slightly up in the air, again, because I don't want any arching at this point. And both of those core muscles are working, the trunk, flexors and extensors, and then lower down slowly. Okay, and now do straight arm. My progression is straight arm. Okay, and just keep this steady. And then my progression is lift one leg and lower down, lift the other leg and lower down, lift one arm and lower down, other arm, and lower down. And now one leg opposite arm and lower down and opposite sides and lower down and gently to your knees. As I said, she's really strong and in great shape, but this is the progression that I would use. And I have my 90-year-olds doing planks, so you know it's not something that I don't expect of my older patients. I really do. Now let's do a couple of side planks. So first go on your forearm on your side, and let's do it this way. Bottom knee bent to your chest, top leg out straight. And just push your butt up and reach this arm to the ceiling. So this would be the first way I would start a side plank. And then what I'm going to do is progress lower down slowly. Okay, and then straighten the legs out, bring this foot in front, and again, do the same thing. So I'm making it slightly harder each time for her, and then lower down. And now I'm going to put her in a straight arm position. So extended arm. Okay, push up, reach out. And hold. And I don't stack the feet in most of my patients because that's just too hard. But my progression here is now I want you to do 3 pelvic dips. 1, 2, and 3. 3 pass unders. 1, 2, and 3. And now 3 leg lifts. 1, 2, and 3. And lower down gently. And now we'll let her breathe. So obviously I'm going to be doing this on both sides, but I'm only going to have her do it on one side. Let's go and do a downward dog is in yoga? Okay, let's do a downward dog. Okay, so the important thing with a downward dog is that I would have her bend her knees a little bit and then flex her butt, push your butt up in the air further. Keep them back. Okay, push your butt up in the air. Shift back. There we go. I want this very straight spine is what I'm looking for. I don't want that rounded spine. So if she has to bend her knees to do that, it's fine. And then the progression of this will be to raise one leg up in the back. Yeah, straight up. High as you can. There we go. Perfect. And then lower down, and then raise the other leg up. And again, I don't care how much flexion she has of those knees. It's irrelevant to me. If she can do, and lower to your knees. If she could do it perfectly straight, that would be fine. I also, backing up just a little bit in terms of some ease, let's do a little bird dog. So that's right arm and left leg out in the air. No, just out and one leg. Perfect. Keep it out straight. And again, I'm always looking, so she's looking down. I don't want her hyperextending. And lower down, and then reverse sides. And lower down. And now the progression of this is right one leg, opposite arm, out in the air. Yep. Opposite, no, opposite. And this arm, good. And now bring elbow to knee under your stomach. 1, and straighten out. And 2, and 3, and then lower down. And then reverse, left arm, right leg, and meet. And 2, and 3, and lower down. Good. Okay. How am I doing time-wise? Somebody give me a little clue. Am I okay? Time-wise, what do I have left? Finished? Okay. Just a couple of quick stretches. Stay right where you are. Give me, again, child's pose. Arms out straight as much as you can. I like this stretch for the spine, and I like it for my aging adults as well. It gives them very, very good range of their hips and their knees. Another thing we can quickly do is legs crossed, tailor fashion. Okay, and curl down. And that's assuming that, again, that I want flexion. If I don't want flexion, I'll do this with a hinged spine, so the spine is straight. And then I can do, let me just show you one quick strengthening for your legs. Bend this leg, bend this one up. Wrap your hands around it. Yep, perfect. Lift this leg up and hold it. And this is really, really solid contraction of those quadricep muscles. So if you want to strengthen the quads, this is one way to do it. Okay, lift up and roll out, externally rotate. And hold again, hard. And then roll in, and then just pump. Good. Great. And you can do wall slides. As I said, the numbers of exercises are as many as you can possibly think about, and it is unlimited. My main aim is to have my patients challenged, and again, loving what they do and feeling so much better because they're doing it. But I know deep in my heart that the thing that makes my patients get back to work, get back to their lives, is, again, the strength of that core and the strength of their body, the flexibility of their body, and being able to handle all of their tasks that they would normally do. So I think I'll stop right here. I thank you very much for, again, your indulgence. It's been fun.